And thanks so much to the Petrie-Flom Center for bestowing upon me the distinct honor of addressing you on the occasion of your 20th anniversary. About 20 years ago, Professor Elhaig actually invited me to speak soon after I left my position as general counsel. So in some respect, this is very poignant and a full circle for me. Health policy is one of the few subjects that literally directly affects every single person in our society, regardless of age, regardless of health status. Even in crude economic terms, it accounts for, by some estimates, 1 in 5, perhaps more, of every dollar spent in the country. And yet, despite its importance, when I was in law school, there wasn't a Petrie-Flom Center, and I'm not even sure there was a single course on health law. I could be wrong about that. But certainly was not a well-studied subject. Having a center like this one here today allows us the opportunity that I did not have when I was in law school of reflecting on the state of our health law and policy-making functions in this country and considering ways in which we can improve our process for formulating a coherent national health policy. Now, any discussion of that nature of a national health policy in a sense implies a false premise, and that is that we have a single national health policy, or let alone a national health policymaker. And of course we don't. One reason that's fairly obvious is that despite some of the things that Sam correctly pointed to, we still have a significant division of authority between the federal and state governments in the area of health law. States license medical professionals and regulate the practice of medicine within their states. HHS, for its part, does not have direct authority to regulate the practice of medicine as such. And hospitals are certified and regulated largely by state inspections and a cooperative process for Medicare enrollment with the federal and state governments. Even when it comes to the requirements of commercial health insurance, which still insures a very large percentage of Americans through employer group health plans, those are also regulated largely at the state level. Today I'm going to address a different type of impediment to the formulation of a coherent national healthcare policy, and that is what I consider the unfortunate division between enforcement and policymaking functions within the federal government itself. And I'm going to end by proposing some potential reforms to address it. The primary healthcare agency at the federal level, I think, is widely considered to be CMS. But CMS has very limited authority to directly regulate healthcare. It does not regulate, as I said, the practice of medicine, or decide what particular treatments are permitted or even required. It regulates, quote unquote, by making payment decisions, by deciding what types of services it will pay for. Even when it comes to, on the Medicaid side, it has some authority in terms of reviewing state Medicaid plans, but again, the focus there is largely on payment rather than the direct practice of medicine. Now, one of CMS's sister agencies, FDA, is obviously FDA. When it comes to prescription drugs and biologics, the FDA comes closest, I think, to a national healthcare policymaker. It has the exclusive authority nationally to approve or withdraw drugs from the market and to specify the approved indications for which those products may be labeled. But even here, once a drug is approved by the FDA for sale, FDA has no authority to regulate the uses for which doctors may prescribe them, pharmacies may dispense them, or patients may take them. Indeed, CMS won't even necessarily deny coverage for an indication that FDA has decided not to approve if those indications find support in certain private compendia. So in all these respects, even when it comes to national policy, with respect to the availability of life sciences products, the federal government's ability to formulate a single coherent national policy is more limited than typically acknowledged. To make matters worse, and what I'm going to focus on for the rest of my talk, today's significant degree of health policy is being driven by two agencies that aren't even healthcare agencies at all. Through the interpretation, administration, and enforcement of criminal and civil punitive statutes that in one case isn't a healthcare statute, and in another is only indirectly or obliquely a healthcare statute. The criminal statute to which I refer, the Federal Anti-Kickback Statute, or AKS, is at least focused on the subject of healthcare. Its language is extremely broad. I'm not going to try to read it all out to you, but its key provisions make it a crime to knowingly and willfully offer or pay any remuneration, directly or indirectly, to any person to induce such person to either refer an individual to a person for the furnishing of healthcare services, or to purchase, order, or recommend purchasing any item that's paid for by a federal healthcare program. Now, the key words, remuneration, recommending, referring, almost every single operative term is not defined in the statute. And its literal terms are so broad that they sweep in lots of conduct that no one believes is improper or the Congress meant to criminalize. I'll give just one example that you've all witnessed. So we all watch TV, I would think, and you've seen at least once in your life an advertisement by a drug company promoting its drug. What you've probably not thought as you've watched is that every single one of those is at least literally a violation of the criminal anti-kickback statute. Each one of those involves the payment of remuneration in the form of money to a person, either an actor or in some cases a former patient, for recommending the use, i.e. purchase, of a drug that's paid for by a federal healthcare program. Now, the government would never bring a prosecution like that. They understand that there's no way the Congress would have intended to criminalize such behavior. But the point is that the breadth of the language means that the enforcement agencies are vested with tremendous discretion to determine what they consider to be a unlawful kickback that they're going to prohibit and punish versus what on the other end of the spectrum might be actually beneficial from a healthcare policy perspective. But the two agencies that currently are empowered to exercise that discretion and make that determination are not healthcare agencies. They're the Department of Justice, which brings criminal prosecutions or civil damages cases to enforce the AKS, and the agency entrusted to adopt regulatory exceptions to the anti-kickback statute, which are known as safe harbors, and to issue advisory opinions as to the AKS's reach, is the HHS Office of Inspector General, which, if you forgot everything you know about healthcare, has to be an incredibly strange choice to vest that power in. The Inspector Generals were established under the Inspector General Act of 1978, and there's one in each department. And the functions that they're supposed to exercise under the Act is that of an internal watchdog. They do internal investigations, internal audits. To ensure their independence and effectiveness, the IG Act insulates inspectors general from removal and supervision by the department heads. Only the president himself may terminate or fire an IG. And even more important, the Act states that the heads of the departments may not, quote, prevent or prohibit the inspector general from initiating, carrying out, or completing any investigation. So they're completely not controllable by the department head. And because they're insulated in this way, the Act actually, if you read it, prohibits department heads from delegating to their inspector general any, quote, program operating responsibilities. In short, the inspectors generals are insulated from control by policymakers precisely because they were intended to be purely internally facing. Notwithstanding that, and consistent with that, actually, the anti-kickback statute itself designates delegates to the secretary of HHS the authority to issue these advisory opinions and regulatory exceptions. But notwithstanding the prohibition in the IG Act, years ago, a secretary of HHS delegated to the inspector general the authority to exercise these functions. Now sufficient time has passed, I think you could make an argument that Congress may have even ratified that at this point. But it should come as no surprise that placing this role with the inspector general would lead to actions that undermine and impede the secretary's overarching ability to implement and pursue sound healthcare policy. So before I turn to some examples of these types of frictions and impediments, I just want to briefly talk about one other major player and another statute, and the player is DOJ, and the statute is the False Claims Act. The False Claims Act provides for treble damages and extremely punitive penalties against entities that knowingly submit or cause to submit a false claim for payment, or who knowingly conceal or avoid returning an overpayment. The FCA itself doesn't define what a false claim is. It doesn't define what makes a payment an overpayment. For that, the DOJ and the courts are supposed to turn to the terms of the substantive programs themselves to figure that out. But again, many of these program requirements are very ambiguous. And so as a practical matter, the power to bring enforcement actions in this way means that is the power to actually create healthcare policy. And so, but the problem is that DOJ is not supposed to be the national healthcare policy. It's not a healthcare expert. And its prosecutorial decisions in bringing these cases sometimes conflict with the views of HHS. And this problem in the False Claims Act area is exacerbated by the fact that those suits can actually even be brought by private relators, whistleblowers, who can bring those suits even where DOJ has investigated it and determined that the suit is not worth pursuing. So I'm just going to briefly bring to your attention a couple of real-world examples where these kinds of frictions and inconsistencies have emerged. The first example involves drug access. Many of the most innovative drugs and biologics are obviously very expensive and unaffordable, even to people with insurance. And even where there's a federal program like Medicaid that will cover co-payments or co-insurance, the resulting cost of the drugs result in heavy expenditures for taxpayers. In response to public reactions to this issue, a number of drug manufacturers have attempted from time to time to establish patient assistance programs in which they provide financial subsidies to patients who can establish certain criteria of financial need. And typically those take the form of vouchers or other payments that are used only after a physician has first prescribed the drug. Despite the potential benefits of such programs, the OIG has taken the view that such programs raise anti-kickback concerns. They're payment of some form of money to induce a patient to take the drug that they otherwise wouldn't take because they couldn't afford. And so to avoid this exposure, which is very significant, manufacturers often and quite typically exclude all participants in federal healthcare programs from the scope of these assistance programs. So the counterintuitive result then becomes that the anti-kickback statute, which was designed to remove incentives for overspending and overutilization, is being enforced in ways that actually discourage programs that could result in net savings to both patients and the government. Another example in the prescription drug context that's occurred over years is one involves the issue of patient adherence. One obstacle to improved health outcomes for patients, according to a number of health experts, is that even when they're prescribed the right drug and even when they can afford them, they don't always adhere to their drug regimen. They may forget to refill their prescription or for any reason fail to take the drug regularly as prescribed. Now, pharmacies try to address this problem through automated refill reminders, and I'm sure many in the audience have received over time, probably all of you. But certain types of obstacles to adherence require some human interaction, counseling on side effects, for example, or the like. And pharmacies themselves do not make enough in dispensing fees or margin on the drug to fund or and engage in those counseling programs. Drug manufacturers do have the funds and they obviously have the incentive to do it. But again, when they've tried to set up these kinds of programs in the past, they've been confronted allegations that they, in fact, by doing that, are violating the criminal anti-kickback statute because they're, again, paying someone, whether it's a contractor or whoever, to recommend the taking of a drug when they call to remind you that you've got this drug to take. So a final example that I'm going to use is actually not in the drug context, but it's involved allegations that have received a fairly high scrutiny in the papers recently over the last few months. And that is a whole debate involving Medicare Advantage plans. So hopefully you guys all know Medicare Advantage plans are private insurers who agree to insure Medicare beneficiaries whose care would otherwise be covered by CMS in exchange for capitated payments from CMS. Essentially, CMS pays a premium to these plans to insure beneficiaries. Those payments are risk adjusted, meaning that plans are paid more to insure individuals who are sicker and hence more costly. In order to try to figure out how sick their beneficiaries are, it's a fairly common practice in the industry for plans to arrange for their beneficiaries to be visited in their home by clinicians who perform health or risk assessments to document all of the beneficiaries' conditions. And the plans then submit those diagnoses, and obviously they get paid more money. As I said, these have been subject to a lot of debate and controversy. Proponents of these practices say that they help close gaps in care, they reach underserved communities, they provide beneficiaries with knowledge as to health conditions that they're not following, and they help to ensure that they follow up on their conditions with specialists. Opponents focus on the increased costs to CMS from the resulting increased premiums, and question whether conditions that have only been documented in a home visit either truly exist, or if they do exist, they're not otherwise being treated. Do they really represent a planned liability for which increased payment is appropriate? Now, those are legitimate questions, both sides. I think there's a legitimate debate there. But CMS has actually looked into this issue, and it's looked into it twice. It looked into it in 2014, and it decided there that it felt that the benefits of home visits and closing these gaps of care outweighed the potential counter risks. And then just very recently, the OIG issued a report hostile to these practices, and CMS, in a pretty rare move to a sister agency, a component within HHS, actually wrote a formal, effectively a dissent, saying they don't concur with the recommendation and they believe these practices should continue. Now, you'd think on an issue like that, CMS should basically be the controlling word. It's got equities on all sides of the ledger. It's the one that's going to make the payments, the resulting higher payments. It's also the one that's, if you will, responsible for the, at least in some sense, not legally, for the health outcomes and better health of their beneficiaries. Yet, despite CMS's clear position twice, looking at this and saying that these types of programs are okay, it's been reported in the paper that DOJ and the OIG are nevertheless investigating these as potentially improper and illegal practices. So having enforcement agencies seek to punish practices that a regulating agency is well aware of and has affirmatively concluded should not be barred, I think obviously impedes the development of a coherent national policy, regardless of which position on this debate you take. There just should be consistency between our enforcement and our policymaking functions. So I began by saying that I would propose certain reforms for your consideration, and so I'll quickly do that in my remaining time. First, I believe there should be strong consideration given to the creation of an enforcement arm within HHS and consolidating the enforcement of fraud and abuse laws across the federal government in that HHS component, shifting it away from DOJ. That component, in my view, should be headed by an undersecretary, who thus would be of equal rank to the head of CMS, but separate from it to allow the enforcement arm sufficient independence to assess whether CMS rules were truly violated by the practices at issue. At the same time, the undersecretary would report directly to the secretary, just as do the policy and payment arms within HHS, and thereby ensuring that enforcement furthers and does not undermine the achievement of the broader healthcare goals with which the secretary is entrusted. And when I say the secretary, I'm talking about the institution. I'm not talking about the current person who holds that position. I should probably make that clear. Unification of regulatory and enforcement functions within a single expert agency has existing parallels elsewhere in the federal government. If you think about the FTC, you think about the SEC, there are other examples. And I'll agree to some extent. As part of this consolidation, I would also advocate for transferring the OIG's programmatic enforcement functions, including the adoption of the safe harbors and advisory opinions, its ability to exclude and otherwise punish industry participants, and its authority to investigate external entities to this new Undersecretary of Enforcement. This would place those functions under the supervision and control of a politically accountable agency head who's supposed to have expertise in the healthcare space, while restoring the Inspector General to the functions that an insulated and independent IG was originally intended to perform, which is that of being an internal watchdog and performing internal investigations, not doing external enforcement. There's obviously a lot that can be said pro and con those proposals, and I'm happy to take any questions on that or on Any other subject you want to ask me about?
So you're right that the Department of Justice is not a health agency, but for years they have had something called the Consumer Protection Branch, which has lots of years of built-up experience at enforcing the Food and Drug Act and other federal health statutes, and the Trump administration has dissolved that, and I think its last day of existence is September 30th, last I checked. Based on your experience, can you reflect on whether that's just going to worsen the problem that you're describing?
I guess it depends who's replacing them. I think I'm still one of the few people who had a senior position both at HHS and I was in the civil division, so overseeing in part Office of Consumer Lit, as it was called then. And, well, never. First of all, I mean, there's an intra-baseball issue. The OCL has always been a bit of a strange placement within DOJ itself because a lot of the FDA enforcement is criminal. It's always was weird to me why I'm, as a civil lawyer in the civil division, overseeing a criminal. They have a lot of expertise. Obviously, they're not, as you said, themselves healthcare experts. I think one thing that helped them in their work is that their client, I'm using that term very loosely, but the entity that essentially they would consult with was FDA's OCI, which I think is I would say is less controversial than the HHS OIG. I think more substantive. Not that the OIG is not, but it's become the problem right now. And one of the things I see with the enforcement is they all compete for these press releases about, oh, I recovered 200 million, or I brought this prosecution, and it's not always directed to the right health outcome. I think the question is going to be, it'll be interesting to see who takes that function. For years, people have talked about moving that to the criminal division. If that's what's going to happen, that actually was something that was proposed across administrations for decades, literally, and never actually done because inertia has its impact. I think it makes more sense to have the criminal division, not the civil division, enforce a criminal statute. Whether, obviously, wouldn't be surprised if there's more at stake there or more at issue there or more debates about that. The whole question of off-label prosecution has always been controversial. Republican administrations, again, not this one only, but going back, several administrations have taken the position, have been more receptive to the argument that the First Amendment actually prohibits those prosecutions. Democratic administrations have tended to take a more aggressive enforcement position on that. So some of that may be going on, and some of that, again, may be within the realm of legitimate debate as opposed to some of the other things that we're seeing.
So I appreciate your comments about the False Claims Act in particular and the references to the key TAM, the private enforcement mechanisms. And I'd just be curious in your sort of stepping back in your overall assessment of this rather peculiar feature of American law that does create this role and gives sort of an independent place for district judges to take an arm's length determination of whether something is illegal or not. Do you think it's on net been helpful, or one could read your comments as suggesting that it's mostly more trouble than it has value, more distracting or scrambling than the value it might have in uncovering real fraud?
So I think the answer is not static in time. I think if you look back, say, 30 years ago when the enforcement started really ramping up, there was a lot of low-hanging fruit, if you will, of conduct that pretty much everyone would say, well, that's fraud. That you shouldn't be able to do that. I think what's happened over time, as I said, there's like you can look at the DOJ website and every year we're touting here's how many billions we recovered and whatnot. I think there's been generally more focus on compliance, and so now you're going after things that are less clearly illegal and more an issue of interpretation. I think if you truly had a unified, that's why I would make that proposal, I think if you had someone who was accountable to ensure, to think about and balance the healthcare consequences of some of the enforcement activity and the policies that effectuate, there'd be less of an issue than now where that's not happening. And again, we talked about who the counterpart was. So it's not only that DOJ has this Civil False Claims Act, their client, in other words, when they call over to HHS to ask, hey, do you think it's a good idea to bring this suit? Their contact is OIG, which is, again, not accountable to the secretary, not in sync always, and often not at all with CMS or FDA. And so I think that has created a real issue, and I think it's exacerbated by what you talked about, the key TAM, where you then have private whistleblowers and really law firms, they just find the whistleblower often, motivated just by trying to get a monetary recovery, and not any of the overarching policies, being able to pursue claims even when DOJ decided not to. Now that one is interesting because you now have had 3 Supreme Court justices say they think that's unconstitutional. On somewhat of the similar line of thinking about the unitary executive that Sam touched on and I think criticized, but there's been at least one district judge who's held that. So I think that's an interesting question. It's been around for a long, long time, but it wasn't tested. There was a case called involving Vermont in the 80s, which talked about a related question, which is whether private relators had legal standing to bring the case, but it didn't touch on, it expressly said we're not touching this other question. And so the question actually has never been resolved as to whether you can really just take what's effectively a core executive function of enforcing the law and give it to a private person and just say run with it. So we'll see. As I said, it's been around for a long, long time, but you've got 3 justices on record saying they think that's unconstitutional.
Time maybe one more quick one if there is one. Going once. There we go. Okay, Richard, we'll get to the microphone.
I've got a question for you concerning the drug payments for advertising, and you say that's illegal. How do you expect to have these drug companies get these products out to the public without paying for the advertisement?
Okay, so hopefully I was clear on this. I don't expect that to be prosecuted. My point was that the conduct literally runs afoul of the statute.
Right.
And my point being that the statute therefore is so broadly and overbroadly written that when you write a criminal statute that's so broad that it encompasses conduct no one would think to punish, what you're effectively doing is giving the enforcement agencies tremendous discretion to decide what they think is okay and what they think is not okay. And when they do that, each time they're doing that, they're effectuating a healthcare policy decision. And so if you're going to have that healthcare policy decision should be at HHS, it shouldn't be at DOJ. And so that's why I'm recommending that they transfer those functions to HHS. I doubt they ever will, but that's what I would do if I was in control.
Big round of applause, Mr. Meron.